In this video, we will discuss HAS-BLED score. This is one of the most commonly used score to predict bleeding risk in patients with atrial fibrillation. First, let's quickly go through the study which was pivotal in the development of this practical bleeding risk score. The EuroHeart study was undertaken by Pester et al. In 2010 to develop a practical risk score to estimate the one-year risk of major bleeding in real-world population with atrial fibrillation. Over 3,900 patients with atrial fibrillation with complete follow-up were included in this study, and all univariate bleeding risk factors along with historical bleeding risk factors were included in a multivariate analysis, and a new bleeding risk score, HAS-BLED score, was developed. In this EuroHeart survey, it was observed that increase in HAS-BLED score was associated with corresponding increase in annual risk of bleeding, and the predictive accuracy in the overall population was consistent across several subgroups with the exception of patients receiving either antiplatelet therapy alone or no antithrombotic therapy. Now let's go through the various risk factors which are included in HAS-BLED score. Letter H stands for hypertension, either uncontrolled or more than 160. The letter A stands for either abnormal renal function test, abnormal liver function test, or both. Abnormal renal function tests include dialysis-dependent patients, transplant recipients, or creatinine level more than 2.26 mg per deciliter or more than 200 micromole per liter. Abnormal liver function includes either chronic hepatic disease like cirrhosis or biochemical evidence of significant hepatic derangement, either raised bilirubin levels more than 2 times normal or raised AST, ALT, or alkaline phosphatase levels more than 3 times normal. Letter S stands for stroke. Letter B stands for bleeding, either prior history or predisposition to bleeding. Letter L stands for labile INR, either unstable or high INR, or time in therapeutic range less than 60%. The letter E stands for elderly patients more than 65 years of age. The letter D stands for drugs or alcohol use. Use of medications predisposing to bleeding such as antiplatelets or NSAIDs, or 8 or more than 8 drinks per week. All these risk factors are allotted with 1 point each, and the maximum score allotted to a patient is 9. Now let's go through the how to interpret this score. Pester et al. In 2010 and Lepp et al. In 2011 define the risk of major bleeding as percentage of bleeds per 100 patient years depending upon the HAS-BLED score. In case of patients with the HAS-BLED score in the range of 0 to 1, the risk of major bleeding was in the range of 1% bleeds per 100 patient years. Thus, these patients are at the lower risk of major bleeding, and in these patients, anticoagulation should be considered. In case of patients with the HAS-BLED score of 2, the risk of major bleeding is approximately 2% bleeds per 100 patient years, and in these patients, anticoagulation can be considered. In case of patients with a HAS-BLED score of 3 and more than 3, the risk of major bleeding is more than 4% bleeds per 100 patient years, with the risk of major bleeding being more than 10% in case of HAS-BLED score of more than 5. Thus, these patients are at the higher risk of major bleeding, and in these patients, alternatives to anticoagulation should be considered. Compared to Piskas et al. In 2010, Lepp et al. In 2011 reported significantly higher percentage bleeds per 100 patient years in patients with HAS-BLED score of 1 and more than 1, while in case of patients with HAS-BLED score of 0, there was no difference in the percentage bleeds per 100 patient years between two studies. Later on, for the simplification of the comparison with the other bleeding risk scores, the patients were risk stratified into 3 groups depending upon the HAS-BLED score. Both Zhou et al. And Wang et al. Classified patients with the HAS-BLED score of 3 and more than 3 into high-risk categories, while Zhou et al. Classified patients with HAS-BLED score of 0 into low-risk category and HAS-BLED score of 1 to 2 into moderate-risk category, while Wang et al. Classified patients with the HAS-BLED score of 0 to 1 into low-risk category and the HAS-BLED score of 2 into moderate-risk category respectively. Now moving to the diagnostic accuracy of HAS-BLED score. Yao et al., who studied diagnostic accuracy of the HAS-BLED score in vitamin K antagonist or DOAC-treated atrial fibrillation patients, observed that the HAS-BLED score has moderate predictive value for predicting bleeding risk in atrial fibrillation patients regardless of the type of oral anticoagulants. Now moving to the comparison of HAS-BLED score with the other risk scores. Roldan et al. And Amadeus study who compared the HAS-BLED score with the stroke risk prediction scores for the prediction of major and clinical relevant bleeding in atrial fibrillation patients on anticoagulation, demonstrated superior performance of HAS-BLED score compared to stroke risk prediction scores, and thus recommended use of specific bleeding risk score, HAS-BLED score, for predicting bleeding risk in these patients. Roldan et al., who compared HAS-BLED score with Atria score, demonstrated significantly better predictive value of HAS-BLED score over the Atria score. A systemic review and meta-analysis by Wang et al., which compared HAS-BLED score with Orbit score, demonstrated modest discriminatory capacity of both scores for predicting major bleeding risk, and compared to HAS-BLED score, Orbit score categorized more anticoagulated atrial fibrillation patients and major bleeding events as low risk, thus underperforming in the bleeding risk prediction. And thus, compared to HAS-BLED score, the Orbit score does not perform better in predicting major bleeding events in anticoagulated Afib patients. Similarly, the other study by Pester et al., which compared HAS-BLED score with Orbit score, demonstrated no significant difference in predictive performance between two scores. Now moving to the other studies which compared HAS-BLED score with other bleeding risk prediction scores, the Amadeus study which compared HAS-BLED score with atria and hemorrhage score demonstrated modest performance of all three risk scores in predicting clinical relevant bleeding, with HAS-BLED score being superior to other two risk scores. And the HAS-BLED score was the only score that showed significant predictive performance for intracranial hemorrhage. In Sinau et al., which compared HAS-BLED score with Atria and Orbit score, demonstrated significantly better predictive accuracy of HAS-BLED score for predicting clinically relevant bleeding. Zheng et al. Compared HAS-BLED score with other bleeding risk scores in patients with atrial fibrillation on oral anticoagulant. And in this study, reduced rates of major bleeding were observed in HAS-BLED low and moderate risk groups compared to other three bleeding risk scores. And thus, in low to moderate risk category, the occurrence of major bleeding evaluated by HAS-BLED score was lower than that evaluated by any of other three bleeding risk scores. In Afib patients in the HAS-BLED high risk category, no such significant increased risk of bleeding events was observed compared to those in the high risk category of other three bleeding risk scores. Thus, the incidence of major bleeding events was higher in the high HAS-BLED score group compared to low to moderate HAS-BLED score group. Thus, this study showed powerful predictive value of HAS-BLED score for the high-risk category Afib patients. Further, the HAS-BLED score showed stepwise increase in the major bleeding events with increasing scores across three risk categories. And patients with HAS-BLED score of 3 and more than 3 showed approximately 3-fold greater increased risk of bleeding compared to those with HAS-BLED score of less than 3. Now moving to the other systemic review and meta-analysis by Zhu W. et al., who compared HAS-BLED score with other risk scores, including other bleeding risk scores and the stroke scores. The discrimination analysis and comparison analysis demonstrated similar predictive values of all bleeding risk scores, with significantly better predictive value of HAS-BLED score over stroke risk prediction scores, while NRI and IDEA analysis demonstrated superior predictive value of HAS-BLED score compared to other bleeding risk scores. In calibration analysis, no significant difference between the predicted and observed bleeding events was observed in low risk and high risk stratifications of HAS-BLED score. Thus, HAS-BLED score performs better than other bleeding risk scores and stroke scores, and thus helping clinicians to make informed decisions. The studies conducted by Keith et al. And Lilrim et al., which compared Garfield AF risk score with HAS-BLED score, demonstrated superior performance of Garfield AF score over the HAS-BLED score. While the other study conducted by Dalgard et al. Demonstrated similar predictive value of Garfield AF score and the HAS-BLED score for predicting major bleeding. While the Prote et al. Demonstrated modest predictive value of both HAS-BLED and Garfield AF scores for predicting major bleeding, with significantly lower sensitivity and negative reclassification value for any bleeding in case of Garfield AF score, and thus Garfield AF score was not predictive of any bleeding, while HAS-BLED score showed a 5% net benefit for any bleeding, thus demonstrating superior performance of HAS-BLED score over the Garfield AF score. Now, the study by Gao et al., which compared European risk score with the HAS-BLED score, demonstrated superior performance of HAS-BLED score over the European score, while the study by Pester et al., which compared HAS-BLED score with ABC bleeding risk score, demonstrated superior performance of HAS-BLED score over the ABC bleeding risk score. Finally, the analysis of various bleeding risk scores in patients with atrial fibrillation by Chang et al. Demonstrated the equal sensitivity and specificity of HAS-BLED and hemorrhage score. The HAS-BLED score is the most balanced bleeding risk assessment tool in terms of sensitivity and specificity. Now moving to the comparison of HAS-BLED score with stroke and other bleeding risk scores in Afib patients on NOACs therapy. All these three trials, which compared with HAS-BLED scores with other bleeding risk scores and stroke risk prediction scores, demonstrated similar a bit modest performance of all these risk scores in predicting NOAC-associated bleeding in patients with atrial fibrillation. In addition, Leib-JH et al. Demonstrated with the major bleeding risk threshold between 1.7 to 2%, major benefit was observed with using HAS-BLED score, while with a risk threshold between 2 to 6%, that is with a higher bleeding risk threshold, both Atria and Orbit scores performed better. Now moving to the trials who studied HAS-BLED score in patients with coronary artery disease. Smith et al., who evaluated the accuracy of HAS-BLED score in predicting serious bleeding events in patients on triple antithrombotic therapy, demonstrated moderate predictive accuracy of HAS-BLED score in predicting bleeding events in patients on triple antithrombotic therapy. While other study which evaluated the predictive performance of HAS-BLED score for long-term survival in patients with NSTEMI without atrial fibrillation, demonstrated that the HAS-BLED score is similar to the GRACE and CRUSADE systems but better than TIMI system in predicting long-term survival outcome in patients with NSTEMI without atrial fibrillation. Then the third study by Capodeno et al., which compared predictive accuracy of HAS-BLED score and the stroke risk prediction score in patients with atrial fibrillation undergoing PCI and discharge on DAPT, showed modest discrimination of both these scores for predicting major adverse cardiac events, with the superior performance of HAS-BLED score over the stroke risk prediction score. In addition, both scores did not significantly predict major bleeding events in non-AF patients undergoing PCI. So now moving to the pros and cons of the HAS-BLED score. First, let's go through the pros of this score. It has been validated in cohorts of real-world and clinical trial patients, and thus compared to other available bleeding risk prediction scores, this score provides better prediction of bleeding risk. In addition, it is simple and easy to calculate. However, it was derived from warfarin-treated patients, not from DOAC-treated patients. In addition, though it is better than other bleeding risk prediction scores, its predictive accuracy is highly variable. So now moving to the indications for its use. HAS-BLED score remains a major and widely used assessment tool as it is simple and easy to use. Instead of or in combination with other bleeding risk scores, it can be used to determine risk of major bleeding, and then by comparing the risk of major bleeding calculated with the risk of stroke calculated by stroke risk prediction scores, it can be used to determine if the benefit of anticoagulation outweighs the risk, and thus can be used as a tool to guide the decision to start anticoagulation in atrial fibrillation patients. In addition, HAS-BLED score helps clinicians to identify the potential bleeding risk factors and take appropriate measures like correction of reversible risk factors, more frequent follow-up to reduce the occurrence of major bleeding events, rather than stopping anticoagulant therapy altogether. Thus, HAS-BLED score does not preclude the use of oral anticoagulants. It rather helps to identify high-risk patients to modify bleeding risk factors. Further, the follow-up HAS-BLED score has more predictive value for predicting major bleeding compared with baseline HAS-BLED score. So these are the references you can go through for further details.